So on behalf of my co-investigators, I'm happy to present the hospital-level variability in the use of intracoronary imaging for PCI in the United States. These are my disclosures. These are my co-investigators, and I have to give a special mention to Dr. Ali Malik, who's one of our senior fellows, put an incredible amount of work into this project. Really a passion project for Ali, and happy to present on his behalf. So intracoronary imaging offers multiple advantages over angiography when performing PCI, from lesion characterization, lesion length, evaluation of stent result, and complications. It's now well established from multiple large registries and trials that intracoronary imaging improves clinical outcomes, reduced target vessel failure, reduced MACE, reduced long-term mortality. Both IVUS and OCT now carry a Class 2A recommendation in the most recent updated 2021 coronary revascularization guidelines. Despite this, existing literature suggests that intracoronary imaging is used in less than 10% of cases in the United States. So the purpose of this study was, one, to describe contemporary trends in the use of intracoronary imaging for PCI in the United States, and two, to characterize hospital-to-hospital variability in IC imaging use. We used the nationwide readmission database, years 2016 through 2020, to obtain a cohort of over 1.3 million PCI procedures. We excluded a small number of patients from sites that performed less than 10 PCIs per year, and the final analytical cohort you can see there is 1.3 million procedures distributed over these 5 years. For the primary analysis of hospital-to-hospital variability, we focused on year 2020 for the most contemporary data. This includes all discharges from 31 states, comprising 62% of total hospitalizations and, 62% of the U.S. population and 61% of all hospitalizations in that time frame. To characterize trends over time, we evaluated the quarterly rate of IVUS and OCT use from 2016 through 2020. And we also described the patterns of IVUS versus OCT use across hospitals. Now I'm seeing my slides here, but we're having a little bit of difficulty there. Okay. Second, we evaluated the variability in IC imaging using logistic regression models with random effects for hospital, sequentially adjusted for procedural, patient, and hospital factors. Sure. From the model, we estimated the median odds ratio, which quantifies the average difference in the likelihood that a given patient will receive IC imaging for PCI when performed at one hospital versus another. So to explain these models a bit further, the first model is an unadjusted evaluation of the likelihood of receiving IC imaging at one hospital versus another for a given patient. To this model, we then add procedural factors, such as the presence of an acute MI, presence of a CTO, and the use of atherectomy. Second, the third model is then additionally adjusted for patient factors such as age, sex, socioeconomic status, and various comorbidities. And the final model is additionally adjusted for hospital factors such as bed size, teaching status, academic status, location, and PCI volume. And the MOR, or median odds ratio, is evaluated across each model. These are the study results. These are the characteristics of patients who had IC imaging versus no IC imaging at the time of PCI. The two populations are actually strikingly similar overall in terms of age, sex, major comorbidities as shown here. The use of atherectomy did differ significantly, with 15% of patients in the IC imaging cohort having atherectomy and only 9% in the no IC imaging cohort. These are the characteristics of hospitals distributed across the quartiles of IC imaging use. You can see that hospitals in the higher IC imaging use quartiles were more likely to be teaching hospitals, and those in the lower IC imaging use quartiles were more likely to be for-profit in structure. This is the relationship between hospital PCI volume and IC imaging use. As the quartiles of IC imaging increases, the mean volume of PCI also increases. These are the trends in IC imaging use in the U.S. during the study period. So from 2016 to 2020, the quarterly rate increased from 6% to 15%. This was driven primarily by an increase in the use of IVUS, although I would note that the use of OCT did increase by a factor of 4, with an absolute rate that remained fairly low. This histogram shows the variability in IC imaging use in U.S. hospitals in 2020, with individual hospitals shown on the x-axis and the y-axis showing that hospital's rate of IC imaging. As you can see at the left here, 14% of hospitals used no imaging during 2020. 31% used some degree of imaging, but less than 5% of procedures. 38% used at least 5%, but not more than 25% imaging. 13% used more than 25, but up to 50% imaging. And 5% used more than 50% imaging. So when you compare the hospitals using routine imaging, more than 50%, versus a minimal imaging, less than 5%, but some amount of imaging, it's a factor of 6 difference. This is the distribution of imaging modalities used across hospitals, and what's shown here is that, as stated, 14% of hospitals use no imaging, indicated by the blue areas. 74% used IVUS only for imaging. 13% used a combination of IVUS and OCT across their procedures, and a very small percentage used OCT only. Looking at among hospitals that did perform some imaging, the distribution of IVUS and OCT is shown here, with OCT in the orange shading and IVUS in the blue. And what you can see is that the majority of hospitals use only IVUS, but among hospitals that used both modalities, there was a wide distribution in terms of the mix of IVUS and OCT. Overall, 1.8% used a majority of OCT, 3.5% used at least a quarter OCT, and 9% at least 10% OCT. This is the sequentially adjusted model, showing that the unadjusted model had a median odds ratio of 4.6, indicating a greater than 4-fold likelihood that a patient would have IVUS or OCT imaging at one hospital versus another. When adding procedural factors, the median odds ratio did not change. When adding patient factors, there was a slight decrease to a median odds ratio of 4.5. And finally, when adjusting for hospital factors, the median odds ratio settled at 4.5. Indicating that any given patient in the U.S. has a greater than 4-fold difference in the odds of receiving IC imaging for PCI at one hospital versus another, irrespective of the factors described here. When we evaluate the median odds ratio over time, what we see is that hospital-to-hospital variability actually increased during the study period. Median odds ratio was 4.0 in 2016, increasing to 4.5 in 2020. So these are the principal findings. IC imaging in the U.S. doubled between 2016 and 2020, but remains seldom used. Most U.S. hospitals use IVUS, and 1 in 8 also uses OCT, but median hospital-level IC imaging is 6% of procedures. There's a greater than 4-fold difference in the odds of a patient receiving IC imaging during PCI between U.S. hospitals, and this difference is not explained by any identifiable procedural, patient, or hospital factors in this study. There are several limitations worth considering. The NRD is an administrative database. It's based on billing claims. Not all U.S. hospitals are included. Operator characteristics, which certainly could influence these findings, are not captured, and some procedural characteristics are also not captured. In conclusion, there's high variability and low overall use of IC imaging during PCI in the United States, and given that IC imaging improves PCI outcomes, our findings highlight the need for strategies to improve adoption, training, and application of imaging modalities to guide PCI procedures in the U.S. This manuscript is now published in SCAI. Thanks for your attention. Happy to take any questions.
So I'm going to take a liberty. Justine and Rob, can you take a picture? So just for everyone to know, first of all, that was fantastic.
Thank you.
It was super high quality and published at the same time. But I want to take this moment to really congratulate Sunil, who was in charge of putting research awards together. And this is historic. You are the first presentation of a research award, right?
Yeah, absolutely.
So stand up there with them.
Thank you.
Stand up there with them. This is a super important day for SCAI, and that was a fabulous presentation. Really, so there's so many questions about it, and you know, it's I guess most of us know this, and the overall utilization is really low. But when your top quartile is barely over 17%, you know that. So how do we change it? So give us some insights into where you think we can make a difference and do that.
That's a great question. So I think we're moving in the right direction. The trends figure clearly shows that. And I think the recent updated consensus statement SCAI has sponsored on interventional training reflects that. So we are moving towards some element of understanding that imaging should be required as part of training programs. We now have a suggestion that 25 procedures in an interventional training program should require imaging. I think that's still a bit low for my taste, but it's something that was not there until February of this year. You know, we need to incentivize it. My anecdotal evidence is that this is a behavior preference. This is physician preference, physician behavior. driven more by that than any patient factor, hospital factor, or anything like that. So if we can find a way to make it incentivized and promote industry training, we need to allow interventionalists to have been out 10 or 15 years, who trained during an era when it was considered not necessary to image every PCI. We need to make people facile with it and able to adopt it easily and feel confident in the interpretation.
I also want to point out there are microphones in the audience there, so if you have questions from the audience, please come up and ask. Any other comments from the panel while we're waiting for people to gather their thoughts?
Yeah, I learned yesterday that Michigan is moving towards a pay-for-performance metric if you're using X amount of IVUS in the lab, so that the lab gets credited for that. So that's an interesting model. When you evaluated this, did you dig into at all, like by NPI numbers in terms of how many years out?
Yeah, we would have loved to have done that. One of the limitations of the NRD is that it does not include any of that information. So the ideal, what I've wanted to do for years was to study this in the CAF PCI registry, but one of the nuisances really is that the data element as it's currently captured in CAF PCI it's only recorded if you record an MLA or an MSA or something like that. So the use of intracoronary imaging to guide PCI is not completely reflected. So but that registry has that kind of granular information. So no, that we don't have that.
Yeah, there was a recent paper that Amir Kaki showed yesterday that looked at, I don't know where they got the data from because I haven't read the full paper, but that looked at quartiles out by training, and that the more recent you are out of training, the more likely you were to use IVUS. And then my second question was, I know the procedural factors you looked at, and it doesn't look like there was much adjustment. Patient-related factors, there was a slight adjustment. Did you look at it all in terms of CKD and contrast use in these?
So we did look at renal dysfunction as a comorbidity, as a patient factor, which did not meaningfully adjust the median odds ratio. Contrast use is not recorded in the database, so that's one of the procedural factors we couldn't account for. But CKD did not seem to have a major impact.
Just a quick comment that we talked about this last year at our think tank at SCAI, and the fact that as we're moving to more complex treatments and so much more calcium treatment, that imaging is critically important for that. And there was a lot of discussion about the same thing, that it's so many operators give it lip service, but really don't either know what they're looking at or haven't had the right training. And so there's really a call for more training and experience as operators get out. I think that's an important message for our society to really help people learn and engage in this, that it's an ongoing training opportunity over a lifetime.
Jeff?
A quick question. Seems like the next obvious question to answer would be, was there a difference in outcome? So if you imaged or didn't image based on those hospitals, any difference in clinical outcomes?
So it's a great question. So we specifically intended not to undertake that in this study because the sense has been that there's such a wealth now of clinical trial data and registry data showing the benefit. So our goal here was not to kind of recreate that, but to really try to understand variability and factors more.
But I think there would be some power in community-based or just general treatment, real-world data to show that difference, right? So the studies are one thing, and then real-world data adds to that. So might be something to consider for your next paper.
Perfect.
So, Sure, yeah. So, excellent paper, obviously, and you're mentioning the operator characteristics. That was put out by our group actually last month. So, we did see that years of training, years of practice. The farther you are from practice, it seemed, for whatever confounding reasons there may be, that there's lower use of imaging. So, definitely the operator characteristics involved. There are regional characteristics involved. We noticed in certain regions of the United States it was less used than others. But it is definitely a mixture of both hospital factors and individual operator-related factors. There's a paper I think put out by the Michigan group with Hitender Gurm, who showed that operators use less IVUS at a facility which uses less IVUS than they did at facilities which use more IVUS. So clearly both these factors are in play, and just like we do in performance measurement, we look at hierarchical modeling. So I think that's we need to see that to isolate what affects more. But certainly, it's great that we're talking about it, and the underuse of IVUS at 6% is really appalling. And I think that's great that we're all talking about it. We also noticed that there was no relationship with operator specialty. So like structural folks are equally not using IVUS as people who only do coronaries, which, the reason we test that is because we thought structural is sort of a new innovation in the field, and folks who are using new innovative devices may also be using IVUS, but that wasn't the case. And there's no relationship with volume either. So some extremely high volume operators out there who use really minimal IVUS, while there are others who use a lot of IVUS. So some of the comments we got in reviewers was about outcomes, right? Because for some reason there remains some suspicion in the community whether IVUS helps or not. And so that was something that we had to address in comments. So I think despite all the evidence, I think that's one arm how we could improve IVUS, is putting the message out there that it really helps. But it's a great study.
Thank you.
I have two comments, and please bear with me with my voice. But in the early 2000s, there was a paper published amongst medicine that you practice how you were trained. Even 20 years later, you're still practicing how you were trained. So I think, and that goes across all aspects of medicine. So I think as the training programs use more and more imaging, and it's in our guidelines, then that will increase on its own to begin with. But downstream, when you go out into the community, it's all about time and money more so, and because they don't see a immediate that these patients are doing worse. Yes, it's in the trials, but it's not an immediate thing that they feel, that it's very hard for them to take the extra time to do IVUS and stuff like that. But I think a lot of that will change just in the education of the fellows that are coming out now.
I think that's a great point. I mean, that's the last kind of editorial comment I would make, is I think as proceduralists, we are unfortunately incentivized for short-term complications and short-term gains, and long-term advantages and disadvantages for patients are sometimes not in the forefront, and maybe they should be. And IVUS in OCT are some of those things that I think offer longer-term benefits.
So you get one little angle on that. It's hard. I always don't necessarily like how people categorize hospitals, like what's a teaching hospital, right? But what was very clear in there is for-profit hospitals. And the fact is right now, hospitals, it's tight, and it is an issue that we do. I think one of the best things we could do from a society is there are clearly specific things, left main, instant restenosis, where really what you have to tie to is you need imaging to get reimbursed for that. That would change it for certain high risk. And I don't know the way overall, and I do think training makes a difference, but I think clearly there are certain things that imaging should be mandatory, right? And if you tie reimbursement to that, you don't get paid. And I think that's how it is in Japan, right?
Yeah.
Well, if there's reimbursement for it, I mean, there's also a case to make to hospital administrators to train one of your techs to be your imaging tech, so that you're not taking the extra 12 minutes or whatever it is to do pre and post IVUS. So.
There's this technical fee. I think that's the issue. There's professional fees. Well, thank you very much.
Thank
Terrific.
you.